Yes, started.
Okay, good evening. Assalamu alaikum all. So myself, Masih Uzzama Khan Nasir, technologist cath lab. Today I am going to present lecture on a cardiac tamponade, a medical emergency. And I will try to cover with this presentation its pathophysiology, diagnosis, and its management. So this is my disclosure statement. There is no conflict of interest. So what is pericardium? Pericardium is a protective fluid-filled sac that surrounds the heart and helps it function properly. A normal human pericardial sac contains 10 to 50 ml of serous fluid, which lubricates the heart. This fluid is an ultrafiltrate of plasma and maintains the hemodynamic stability of the heart by allowing the two layers of the pericardium to slide against each other without friction. In this picture, we can see the inner layer is called epicardium and the outer layer is called parietal layer of serous pericardium. Within that, there is fluid which is giving a cushion effect. You can say shock absorber for minor shock for the heart. It is protective layer of heart. What is cardiac tamponade? A clinical syndrome caused by the accumulation of fluid in the pericardial space, resulting in reduced ventricular filling, compromised cardiac output, hemodynamic compromise, and shock. Key concept, it is a pressure-related issue, not just a volume-related one. The intrapericardial pressure rises, squeezing the heart. So in this picture, we can see a normal heart and one heart which is filled with the fluid, and it is compressing the heart. Compressing means it is not giving a chance of allowing the heart to expand or fill properly. So less filling means less ejection. Less ejection followed by it is directly compromising the cardiac output and stroke volume. Pathophysiology. Fluid accumulates in the non-distensible pericardial sac. Intrapericardial pressure increases. This pressure is transmitted to the cardiac chambers, compressing them. Diastolic filling, as I mentioned before, is impaired. And of course, this is the core problem. Stroke volume and cardiac output fall dramatically, leads to systemic hypotension and cardiogenic shock. Etiology, the causes, blunt trauma, penetrating trauma, like car accident or maybe stab with the knife, and aortic dissection, rupture into pericardium, malignancy, most common issue in developed countries, the cause, for example, lung cancer, breast cancer, lymphoma, etc. Heart attack, of course, and tuberculosis, inflammation or infection of the pericardium, chronic immune disease like lupus, rheumatoid arthritis, and scleroderma, uremia, in patient with renal failure, hypothyroidism, and etc. Cardiac tamponade can also happen after a medical procedure like catheter-based procedure. In case artery is perf, so there is a leakage from the coronary artery that is filling that pericardial sac. That involves heart and or surrounding blood vessels. Placement of devices like pacemaker and other CVT devices. Clinical presentation or symptoms. So main symptoms are chest pain or discomfort, dyspnea, most common symptom, tachycardia, a compensatory mechanism because heart it is started pumping rapidly to fulfill the demand. Beck's triad, often not all present. So these are three main: hypotension, jugular vein distension, increased central venous pressure, and muffled heart sound. Muffled heart sound means the sound of heart is decreased, which we can see in pleural effusion and if patient is obese, and of course in cardiac tamponade. Other signs, pulsus paradoxus, decrease in systolic blood pressure more than 10 millimeter of mercury during inspiration. tachypnea, signs of shock, cool, clammy skin, confusion, oliguria. Diagnosis. Clinical suspicion based on history and physical exam. Beck's triad, pulsus paradoxus, I mentioned as in previous slides. Echocardiography, that is a gold standard and most reliable bedside test. Visualizes the pericardial effusion, shows right atrial systolic collapse and right ventricular diastolic collapse, shows inferior vena cava plethora, distended inferior vena cava with minimal respiratory variation. ECG, of course, often shows low voltage and electrical alternance, QRS complexes. Chest X-ray may show a water bottle shaped heart if large effusion is present. CT scan and MRI scan also can be helpful. So in this video, we can see in echo, the heart and surround heart, there is effusion. So heart is swinging like anyway. So this is the most critical and rapid diagnostic tool. Quickly, you can diagnose with the echo. So in this picture, we can see X-ray image. One image is a normal heart, and second image we can see, just I will open my pointer. So here we can see water bottle shaped heart. And here in this image, we can see the pressure waveform directly showing pulses paradoxes. During inspiration, the systolic peak to peak pressure is decreased more than 10 millimeter of mercury. And in ECG, we can see clearly the electrical alternates, QRS complex variation. Management. ABCs, airway, breathing, circulation can be applied if required. Aggressive fluid resuscitation temporarily increase preload to help fill the compressed heart. Inotropes may be used to support blood pressure, for example, norepinephrine, dobutamine, etc. And most important thing is to avoid diuretics, nitrates, and other vasodilators. They can decrease preload and can worsen the situation. So avoid these diuretics and vasodilators. Prepare for emergent pericardiocentesis. And this is the treatment. Definition of the treatment: a procedure to drain the fluid from the pericardial sac. It is called pericardiocentesis or pericardial tapping. Approach often done under echo or fluoroscopy guidance. And the approach is most commonly taken, that is sub-xiphoid approach is common. Procedure: a needle, a regular guide wire, and then a pigtail catheter are inserted into the pericardial space to drain the fluid. Outcome is very nice, dramatic, and immediate improvement in hemodynamics can be seen. Surgical management indicated if pericardiocentesis fails or is not possible, fluid is loculated, clotted, or recurrent. So if it is continuous draining after this removal or tapping, or the blood is clot, so pericardiocentesis cannot be helpful. In that case, we have to refer to the surgical side. Underlying cause requires surgery like trauma, aortic dissection, and the procedures in surgery, that is pericardial window, creating a small opening in the pericardium to allow continuous drainage into the pleural space. Pericardectomy, surgical removal, or part of all of the pericardium from the surgeon side. Okay, complications. If untreated, cardiogenic shock, cardiac arrest, pulseless electrical activity, and sometimes death can take place. Procedure-related complication, that is a laceration of coronary artery or chamber, infection, and pneumothorax. Prognosis depends on the speed of diagnosis, treatment, and the underlying cause. Pericardiocentesis in cath lab, which we are doing in our cath lab, and the item requires for pericardiocentesis includes pericardiocentesis kit, or individual sterile components such as needle, guide wire, and epithelial catheter, etc. Imaging equipments, that is very important, under the fluoro or ultrasound or echocardiographic guidance. The procedure also requires local anesthetic, lidocaine, fluid collection equipments, and vital sign hemodynamic monitoring devices. This is the kit which is available in our cath lab that contains 6 French optical catheter, a 0.35 inches into 80 centimeter guide wire, 18 gauge needle, dilator, drapes, scalpel 11 number, and 60 ml syringe, 10 ml syringe for the lidocaine, 60 ml syringe for the aspiration. And of course, there is a waste disposal bag. In this kit, there is a cable which is called alligator clip. Both sides there is tip looks like alligator mouth. So what we are doing with this clip, one end we are connecting to the ECG monitor, and other end we are connecting to the needle. So once you are puncturing, if accidentally you are hitting the myocardium, so you can see quickly ventricular ectopy or QRS ST elevation you can see. So what you have to do, you have to pull back slightly the needle, and you can get access again. Patient preparation, IV lines, of course, for the fluid, for the drug. Patient's position, semi-reclining position, 45-degree is recommended. If patient cannot uh, tolerate this semi-reclining position, we can go for supine as well. So semi-reclining, it is recommended because due to gravity, all the fluids will be accumulates at the apex of the downside of the heart. So easily it can be aspirated and at one place. Set of vital sign monitoring to monitor blood pressure, breathing, and heart rate, SpO2 and ECG, etc. Approaches. There are three common approaches: parasternal above the breastbone, and substernal or subxiphoid, the commonest access, and the apical. In this picture, we can see A, B, and C. Usually, we are taking B position, that is subxiphoid, that is the commonest. And there is one blind approach also, but it is not recommended. It is only be done once there is no other option available during the emergency. And it is done without any fluoroscopy or without any ultrasound guidance. Typically, so it can be done either in at bedside or emergency department. These are the steps for the pericardiocentesis. We can see that examine the patient and identify the void process. And in second picture, we can see he is puncturing the site by taking the angle at the left shoulder. And during puncture, continuously give negative pressure with the syringe. So if you are at the sag, you can get the aspiration. Once you get the aspiration, just insert the wire inside, and always keep an eye on the ECG monitoring. So number 5 picture, we can see a guide wire is inserted. Once guide wire is in, remove the needle, and you can use a sheath or dilator. In first video, we can see subxiphoid approach with micropuncture set is taken. And second picture, we can see a 0.035 inches guide wire being inserted through the pericardial sac. And third picture, we can see the guide wire is making a loop around a heart. Post procedure, send fluid samples to the lab for testing. Of course, results can help to figure out why patient had fluid buildup in the first place. Repeat an ultrasound echocardiogram to confirm the fluid is all gone. Doctor will perform an echo daily if patient has catheter left in place for further drain. Pull the catheter out after confirming that the fluid is completely gone. Benefit. Besides being a life-saving procedure when the heart is under pressure from fluid around it, a pericardiocentesis is very helpful, can help to collect fluid samples that will show why it happened, the cause in the first place, which can help doctor to treat the underlying problem and can take place in hospital, bedside, cath lab, or in operating room, of course, is faster and less invasive than surgery. That means it's usually a better, faster option when patient has severe symptoms from cardiac tamponade and he is at risk of heart stopping. Success rate. Studies have found success rates higher than 90%. That is very good number, and with some as high as 100% also. Depending on the cause and treatment options, fluid can continue to build up after the initial drainage. If this happens, doctor might recommend patient to see a surgeon to discuss a more permanent procedure called a pericardial window. If it is taking place again and again, removal of 5 to 10 ml may increase a stroke volume by 25 to 50%. That is very good outcome. Complications. Pericardiocentesis complications happen in about 5 to 40% of cases. The risk of complication is lowest when it was done under imaging guidance. So imaging guidance is very important, like fluoroscopy, ultrasound, or echo guidance. Pericardiocentesis and surgery can have the following complications, like bleeding, injury to the heart chamber or surrounding blood vessels, collapsed lung, pneumothorax, air in the pericardium, pneumopericardium, heart attack also, and pulmonary edema, infection, irregular heartbeat, arrhythmia, injury to nearby organ, including liver, lung, or stomach. So in this echo video, we can see the heart and that pericardial fluid. It is there. If you see the arrow, yellow color arrow, and other video we can see after removal of 600 ml drain. This is a small video for educational purpose.
On the stone trolley, 20 milliliter syringe with local anesthetic agent.
So we are taking syringe for the lidocaine, scalpel 11 number.
15 centimeter, 18
He
gauge
is using a long needle. Usually we are using 18 gauge small needle. That usually we are using for femoral approach. And of course a guide wire. And this is long sheath, but we are taking 11 centimeters, usually thick French sheath, and a pigtail catheter.
Chosen area is sterilized.
Area will be prepared by betadine and draped by a cut sheet. Then lidocaine given.
And the instrumentary.
And there is a small nick by number 11 blade. So
the needle contains the urine contrast.
With this needle and this syringe attached, this is half-filled saline. During the puncture, we are always taking a negative pressure. So once you are in the sac, you can get the fluid in the syringe.
30 to 45 degrees to the skin.
And angle will be 30 to 45 degrees and pointing towards the left shoulder. Sometimes doctor is pushing contrast also to double check that he is at the right position.
The contrast agent injection, the inferior position appearance of sluggish layering of the contrast medium, the needle with negative back pressure until pericardial fluid is aspirated. The bloody aspirate may indicate myocardial puncture
So he
or
got
hemorrhagic
the
pericardial
aspiration
effusion.
back. That means
Therefore,
position is
the
correct.
extracardial.
So after that, to double check, he can do, doctor can do a agitated saline injection also, taking two syringes with the three-way to agitate
Position of the tip
and
of the
push
needle
into
can
the
be
sac.
by injecting agitated saline
And we
through the
can
dual
see
needle.
with the help of echo
The
or
bubbles
ultrasound
can be
guidance,
visualized
the
through
bubble.
echocardial beam
See?
in pericardial space. The contrast creates a nice insert
So once
soft-shaded guide
position
wire
is
into the
confirmed
pericardial
by
space.
echo, by fluoroscopy,
Wire should be wrapped around the heart,
one wire is
present
inserted,
in the specific vessel structure. If
then
vertical
needle will be
antisystoles occur,
out
check
and
the wire's
a
position
pictal catheter
with an
can be
introducer
inserted.
wire into the pericardial space.
There's sheath inserted, and after that, pigtail is
We'll
subsequent.
throw the introducer. Inserting metallic sheath may be
So
helpful
this is the
in
pigtail catheter.
situations when a big teeth or
And if you want to keep the pigtail catheter for a long time, 1 day, 2 days, so you can suture and leave it. Excuse me.
understand.
So facts. Rate of fluid accumulation is often more critical than the volume of fluid. Slow accumulation of a large volume up to 1500 ml may not cause tamponade. That is very important. But a relatively small effusion, about 150 ml only, can do so if it builds up too rapidly, because the pericardium cannot stretch so quickly enough to accommodate it and giving symptoms. Traumatic events usually lead to faster fluid accumulation and are therefore more dangerous. Summary. Cardiac tamponade is uncommon but a life-threatening pump failure due to the cardiac compression. Think of it in any patient with shock, elevated jugular vein pressure, and a potential cause. Backslide, as I mentioned in previous slides, is classical but often incomplete. Echocardiography is the diagnostic cornerstone that is a very reliable and very important tool to diagnose pericardial fluid effusion. Fluid resuscitation is a temporary measure. Emergent pericardiocentesis is the definitive life-saving treatment. The process may not cause symptoms, especially when the fluid builds up slowly over the time. So slow accumulation is not that much serious, but fast accumulation is a serious matter. Thank you so much all.
Nasir Bites was the great presentation, really very informative, and we all enjoyed. I know you have to go for your children parents meetings. But before you leave the session, I have one question. The
Yeah.
first question is, dear sir, there is a question. So I'll read that question. So you would you like to answer? Then we'll go with the further. So I'll just read the question and then, dear sir, is the
Yeah.
safe to inject the agitated contrast as it may inadvertently be injected into the cardiac chamber leading to air embolism?
Can you say again, please?
This is the question by the Kareem Khan is, dear sir, is it safe to
Okay.
inject the agitated contrast as it may the time of you are injecting in the cardiac chamber going to be lead air embolism?
Exactly, exactly. In many cases, but in cath lab mostly, if tamponade and doctor wants to reconfirm, so we are just taking two syringes with the saline filled, half filled, and just pushing both sides to generate micro bubbles. Then we are pushing into the sac, and after that checking with the ultrasound or echo to reconfirm.
So hope Kareem, you get an answer by Nasir. One from my side, one question, Nasir, before you leaving. What are the medication that you at the time of you have the temper hard to avoid to give the medication? Like some of the specific medication should not be given to the patient having the temper heart.
Yeah, of course. As I mentioned before, that vasodilators we have to avoid, and this Lasix also we have to.
Classics also. Okay, sure, sure.
Yes, yes, yes.
So anyone
We
else
can
from
we
the
can
panel?
give the medication which can increase the stroke volume.
Okay. Anyone have another question? Please let us know. Then
I think this is the slide in this. I mentioned that norepinephrine and vitamin, etc., can be given. And other hand side, you have to stop giving diuretics. That is, of course, Lasix, nitrates, and as other vasodilators that can worsen the situation if patient is having a pericardial effusion.
any cath lab staff, you want any queries related to the patient having tamponade in the cath lab and they are going for the procedure as and Mr. Nasir already explained very well about how to treat the tamponade in especially in the cath lab because as the patient having the post surgery patient and we are treating in a different way like in open heart surgeries as you already even mentioned in your presentation also that the post surgery can be go for the tamponades like bleeding point of view or something like there's a rupturing aortic dissections and then we're going to open the direct chest and treat the patient to avoid to resolve the tamponade happening for the patient but related to the cath lab and especially the patient was going under the cath lab related to tamponade. If anyone have any question, please this is the time to ask question. You can ask in any bilingual language, not important to just ask the question in English. आप उर्दू में भी लिख सकते हैं, हिंदी में भी लिख सकते हैं, मलयालम लैंग्वेज में भी आप कह सकते हैं, सवाल हम ट्रांसलेट कर लेंगे, तगालों में भी आप कर सकते हैं. So everyone have a right. This is the right place where you can ask the questions.
Yeah, and of course, Urdu can be.
Yes. Any language is acceptable. We can translate.
Cath lab just by most often if during coronary angioplasty there is
Catalina,
perfusion by
sorry,
stent by
sorry,
wire.
Nasir Bhai, there is a Catalina from the South American. She's our colleague. She visited here in Qatar in our ECMO course. So Catalina, you have any question related to the Tempen hat? She's from the US, from the South US, from the Chile. So Catalina, you just mentioned something. I feel like you give some claps. You have any question related to the this talk?
Hello, I just thank you
Hey,
very much for inviting me.
yeah, yes, your
No,
voice is very clear.
the lecture was very good, so thank you very much for everything.
Thank you.
Thank you
Thank
so
you.
much.
Yes. So we are looking forward to get some interesting topic from your side from the South America also. So for the we are waiting for the Chile also to going to present in this platform. So now anyone have any other questions? There is some question related from Fakhruddin. I'll just confirm from him what is his question. There is a question. I'll just read. Dear sir, is it no? This already we answered this one. Who is this Kareem? And then we'll go back to further. Anyone have questions? New message? I was thinking there is a message. I don't.
Tell them it is free. No
Yeah.
charges.
So, but if there will be no question, so you are lucky then. Then we're going to wind up the things if everything is clear. There is a question. If there is a temper because of the, there is a question. Talha Fakhruddin, you can speak up instead of writing. I think, sir, we have a voice talk questions. Yes, please. He can talk. Talha, you can talk. You can open your the mic. Unmute.
Yes, dear sir. I think are you hearing me, sir?
Yeah.
Yes,
Please,
yes.
please.
Thank you so much for this precious and like a very informative insight
Thank you so
to the
much, sir, for
complications
appreciation.
we often see and we observe in the cath lab, especially while we are doing the PCI procedures, while doing the
Exactly.
placing the stand or either maybe to some wide placement. So I really appreciate, first of all, because I think this was just my first presence over here. And dear sir, my question would be that first of all, I asked you the question and I like the voice chat, sorry, the text chat. Again, the same question. If we inject the agitated saline, so there are chances of course, you mentioned that we should be, meticulously careful about the injected, but I'm sure we have been experienced so many times, maybe 3, 4 times, that we got injected because inadvertently into the RVs one time. So, as per my experience, as I'm in the cath lab since 23 to 20 years, so this would be my suggestion, not a recommendation at all. That sometimes I think we should avoid this, the agitated saline, because we can have just to ensure we can ensure it by the echo. I think rest I leave it on you. So
Exactly.
yeah,
Thank you so much for your valuable point. Of course, that is very much valid. And of course, in my slide, I said that is ECHO is the most reliable gold standard tool for this diagnosis of this tamponade. That is, of course, and if you inject agitated saline, there is a risk of always, migration of microbubble. Of course, that is valid point. Thank you so much for this point.
thank you, sir. Thank you. Thank you, sir. Thanks.
Thank you so much.
Thank you
Okay,
for
that's
your
why
valuable
may I
input.
leave because sorry guys, I would like to stay more, but today is my kids' annual day presentation in the
It's there.
school,
Yeah.
so I will leave now. Thank you so much for the attendance and invitation,
Okay,
of
sir.
course. That's why see you inshallah very soon with the new
Very
topic.
soon. Any question in this platform? Any your input? Otherwise, we're going to be end up with the fruitful talk. I'll give 1 minute more. You can leave, Nasir brother. Thank you so much for your great.
Thank you so much all. Thank you so
And you
much.
will continue with your kids
Thank you. Thank
annual
you.
meetings. You will go ahead for that. And our platform is still open for a minute. If there is no question, no suggestion, then we're going to end up for further next session. No questions? Thank you, Talha. Thank you, Saber. Thank you, Abdullah. Thank you, Mariam. Whoever I'll just go through with all the names so that you should know that we are acknowledge you. Hafsa, Talha, Abdullah, Aisha, Dalaviz, Faiza Khan, Fawzia, Inshal Naved, Mariam. Who is the other
Why
one?
is he not mentioning you?
Sayyida Zahra. Yeah. For also. So all of you, thank you so much. Keep joining us with the new session and with new talk. Okay. So I'm going to end up. Have a nice and very good day. Take care. God bless you all. I'm going to end the meeting now. No question till now. Okay. Can we? Bye. Okay. Good night.